Okay, so this is the first time we've done case presentations in a while. So basically what's going to happen is one of the residents is going to go through one of the cases that they've identified in clinic as potentially needing early interceptive orthodontic treatment. And we're going to walk through and diagnose these cases together and decide if they, what type of treatment we're recommended, if we are, or if we're not, why we're not. And so we will get started.
All right, good morning. So we have an 8-year-old Caucasian male. This is my patient. So just going through some of the profile shots.
Sorry, I just wanted to make sure that worked.
Oh, yeah.
Okay, we're good, yeah.
So here's a side profile. He's kind of have a straight profile.
So let's take a look at this profile for a minute. So when we have profiles, we're looking at a number of different options on the way to describe that. So you mentioned one of them is straight. So what are the other ways we can describe a profile, and what is it telling us?
Convex, concave.
Convex and concave. All right. So what do we see in a convex profile? What are we seeing? What are we identifying on the image that's helping us to know it's convex, and what does that mean clinically? Okay. So you have the lower third of the face. You're looking for what if it's more of a convex profile? What kind of characteristics are you seeing? Okay, retrusive mandible, retrusive chin. You kind of see, depending on head posture, you'll see that chin kind of move back a little bit. So what about a concave profile? What are you seeing?
Maxillary deficiency.
All right, possibly maxillary deficiency, right? So if it's more concave and we see it's kind of like ditched in the middle, that could mean maxillary deficiency. What else could it mean?
Protruded mandible.
Yeah, protrusive mandible could mean that. So a straight profile is then kind of somewhere in the middle, right? So when we talk about a normal profile, or what some people will call an orthognathic profile, would that be slightly convex, exactly straight, or more concave in general? Like what's normal? Slightly convex, okay? And so if we're describing this patient as more straight, then what are we saying about this patient, about their jaw? So if normal is slightly convex, and we're describing this patient as straight, then what are we saying about them? What does that mean?
The jaw development's together.
Yeah, there might be more of a class 3 tendency. Now, when you look at this image, if you had to critique, just the image itself, meaning how the photograph was taken, was there anything you would critique with this photo as far as the way it was taken? So head position is a little tilted up. So now if the head position is a little tilted up, is that going to make the profile appear more straight or more concave or more convex? Like what direction is that going to make the profile appear? It's going to make it appear more straight, right? So if we were to have more of a level head posture, probably the chin a little bit further down, then this case would probably look more orthognathic or maybe even a little bit convex. Would you guys agree? Yeah. So it's a good thing to remember is when you're looking at the actual photo, you want to make sure you have, basically from cella to nasion is the plane that you're imagining in your mind. So, you have nasion, and when you look at the ceph, you can get an idea for where cella is, and it looks like a little bit tilted up. So in this case, I would describe it a little bit more as either convex or orthognathic. The profile looks pretty good. What about the nasolabial angle? What are you noticing there?
Obtuse.
Yeah, it's a little bit more obtuse, which could mean what?
The image.
It could be, well, not really the image, because whether you're tilted up or down, the angle is going to remain the same by and large for the most part.
And the anterior dentition is probably a little bit retroclined, so the lips lay a little more flat.
Okay, it could be the anterior dentition, right? It could be that the teeth are tipped back. It could be that the upper jaw is set back, or it could be what? Yeah, it could be upturned nose, right? And a lot of times in kids, their noses are more upturned, and so you see more of an obtuse nasolabial angle. But if you had to, just looking at this profile photo, say, is this maxilla too far forward, too far back, or just right? Like, what are you guys thinking? Pretty close? All right, if you had to pick one or the other, would you say too far forward or too far back? I agree, it's pretty close. I mean, if anything, maybe slightly, if you imagine his head being down a little bit, maybe slightly retrusive in the maxilla. Again, and this is the soft tissue profile, so we have no idea what the teeth are doing yet, no idea what the bones are doing yet, but we're starting to store these things away in our mind so that we can make sure that we are looking for the right things as we continue to process through the images. So what else in this profile photo stands out to you? Like, what do you notice in this profile photo that may not be completely normal or that may not be completely ideal? It probably is a head position. Yeah, so that, again, all these little indicators are cueing you into like where should that head position be when you take the photo. What else? What else kind of stands out that maybe is not as much ideal as it should be or could be? What other features? How about the lower jaw? What information can we get from we talked about the profile, or the convexity of the profile, but ignore that. What other features? Hyperdivergent? Like a little, like lower, longer third, possibly. All right. I mean, if I had to pick between, shorter or longer, I would pick longer. Facial height in general looks pretty normal to me in this image. What other features? What other features can tell us anything that's happening with the mandible? Say it again. I think you're on the right track. Okay, so yep, the mentolabial fold is something. I mean, if anything, it could be a little bit of a downturned lower lip, which definitely can indicate a little bit of mandibular retrusion. Not super severe. There's another feature that if anything is probably more indicative than anything we've really mentioned besides the convexity of the profile, and they go hand in hand. What else is that? Yeah, chin, throat, neck length, right? So when you guys look down here, you can see, does this look good, long, or short? Yeah, it looks a little bit shorter. And why else is that even more significant in this case than maybe another photo that had a short chin, throat, neck length? Exactly. So the heads are tilted up. So even with the head tilted up a little bit, you can see that chin, throat, neck length is still a little bit short. Okay? So when we're thinking about this case, we're thinking, okay, well, maybe there's a little bit of maxillary retrusion. Maybe there's a little bit of mandibular retrusion. One more thing I want you guys to pick up on this image here, okay? So let's look at the middle third of the face. All right? So what do you see or not see in the middle third of the face? And this is more subjective than objective, all right, as far as being able to measure this or not. But when you look in the midface, is there anything that stands out to you? Or does it just kind of look like a midface? All right, so pay attention in your photos. If it's not something that you typically look at, pay attention to the cheekbone area. And pay attention to how much support is there. So when I look at this photo, it looks a little bit what I would describe as midface deficient. All right, the cheekbones seem a little bit less prominent than they might in other kids that maybe aren't as retrognathic. And if you start looking at that, you'll start to develop an eye for seeing it. And that does add up with what the other things that we're saying: slightly retrognathic maxilla, slightly retrognathic mandible. If there is a downward, backward growth pattern, typically we'll see less development of the entire midface. And this makes complete sense because when we expand orthopedically, and we actually move the bones, what happens to the midface?
Down and forward.
Exactly. Just like everything else, it comes down and forward. So you see a filling out of the entire midface. If you guys aren't already members, hop on to Breakthrough Marpy, and I posted a case on Facebook, and I posted a case on there, and I'm going to be posting images soon, the 3D superimpositions of this case. This case had over 24 millimeters of skeletal expansion. Now, I'm not endorsing that amount of skeletal expansion. It's not a case that I treated, and I don't feel that amount of expansion was responsible. And I really don't know how they're going to finish the case in any acceptable way. But what it did show is you can see the extent of midface change when you expand that much. So we're talking about a 1 centimeter movement forward of the entire maxillary complex. It's unlike anything I've ever seen. So, pare that down to normal treatment, and when you do expand, you will get development of the midface as well. All right, any other questions on this photo before we move on? All right, let's go.
So this is just our straight-on shots, so smiling, not smiling.
Okay, so let's start off with our frontal rest view. All right, so what are some of the things that we're looking for in a frontal rest photo?
Facial symmetry.
Okay, so we're looking for facial symmetry. How does that look?
Looks pretty good if the photo's taken correctly.
Yeah, yeah, you could probably correct it a little bit. I mean, eyes and ears a little. You could slant it that way, but taking that out of the equation, you can see face looks pretty symmetric. The chin's not obviously off to one side or the other. The nose isn't obviously deviated to one side or the other. What else do we look for in that frontal rest photo? Okay, so how does lip competence look? Yeah, it looks pretty good, right? I mean, it seems like his lips are at rest. It doesn't seem like he's straining. We don't see mentalis strain, so that looks pretty decent. All right, what else do we look for in this photo? Say it again. Facial thirds. Okay, yeah. So basically the symmetry top to bottom and the proportions of the face, and how do those look? They look pretty good. We had mentioned earlier that the lower third may be a little bit elongated. I would say, you know, if you had to pick between the two, maybe, but I think it looks pretty good overall. All right. So what if I told you this patient had severe sleep apnea? Then what would you be looking for? Okay. All right. So what does that look like? Like that? Okay, right? So you think about this, right? It's really easy to ignore. We're all looking, what is there, 30 of us in this room? We're all looking at this photo and nobody's mentioning it, right? I mean, I think we're all seeing it. Is anybody not seeing it? So when you look underneath the eyes here, you'll see, again, they call them allergic shiners, you know, because they're related to allergies at some point, venous pooling, right? So you'll see sometimes they're darker, you'll see, and the skin above tends to shine or reflect. And then you also see basically the bluish coloring underneath here, okay? Now, granted, this is also fairly subjective. It doesn't mean, it's not a diagnosis of any kind. It's not like, hey, now you have sleep apnea because we see this. But it's also not something that's considered normal, right? So if we're seeing this, again, it's like, well, maybe we start asking questions. This case, I would say, is a very mild case of venous pooling. But if you look online, you can see what it looks like in a more severe form. But again, it's one more thing to push back into the memory bank. Now, what other indicators, again, if you were thinking about this from a sleep standpoint, what other indicators would you be looking for? And I'm not saying it on this picture specifically, but what other things might you see in a patient that might be more likely to have sleep or breathing problems when it relates to the eyes? All right, we got our first impressed me question answer of the day. All right, you've won our gold back. Yeah, so scleral show, right? So going back to midface deficiency, scleral show is directly related to midface deficiency. So the less prominent the cheekbones are in the midface is, the less support there will be of the soft tissues, and you'll see the soft tissues drop, and oftentimes you'll see the scleral of the eyes. You'll see whites underneath the eyes. Now, in this case, we don't see that, right? So, I mean, again, like, I wouldn't call him severely midface deficient, but, you know, there are some indicators that he's a little midface deficient. If you're seeing scleral show, you do want to check to make sure that the head position is right, because depending on where the head position is, that can affect the amount of scleral show. But assuming your head position is correct, then that is something that may indicate a midface deficiency. So again, you're banking these things away in your memory. Let's transfer over to the smiling photo now. What information are we trying to gather from our smiling photo?
Do the teeth follow the lower lip?
Okay, so aesthetically, we want to see, you know, consonants of smile arc here. And what do we see as far as the teeth following the lower lip or not? Let me ask it a different way. If you had to guess what the occlusal plane was in this case, would you guess that it's more flat or more steep? More flat. Okay, I agree. And why? Exactly. So when you look at the smile, you'll see that you see the posterior gums here on both sides, and then when you get to the anterior, you're showing less and less of the teeth. So likely this occlusal plane is a little bit more flat. All right, so here's our first piece of information that's kind of going against what we saw in the profile and frontal rest views of possibly the lower third being a little bit longer. A flat occlusal plane typically indicates a lower third that might be a little bit shorter. So again, we're banking this away and trying to create a big picture of what was happening with this patient. So if why, if the occlusal plane is flatter, which again we'll confirm on the Ceph when we get there, why might that be the case? Why would it be flatter? I mean, because we have normal. I mean, we call normal for a reason. So if we're deviating from normal, there's probably a reason why. So what reasons might this deviate from normal? Let me ask that a different way. What reasons? Well, let me back up even further. Why does an occlusal plane form the way that it does? It just does? Why does it? Okay, I've heard two things. Say what you said again. Okay, Well, does the occlusal plane always match what the angulation of the jaws and mandibular plane angle? No, not always. All right, what was the other thing that was said? Eruption pattern, right? That's definitely something, right? So speak more to that. What happens when you have an ankylosed tooth and that side of the mouth stops erupting or growing? What happens to the maxilla? Let's say you have a lower ankylosed tooth on one side and it limits the eruption of the teeth on that side. What happens to the maxilla? A super eruption. And so the bone itself of the maxilla develops what? If it's on one side and not the other. You would describe the bone as, you develop a cant, right? You develop a cant. And cants aren't normal. But in that situation, we understand that, right? We say, okay, well, you had an ankylosed tooth and that made you develop a cant, all right? When we're talking about the occlusal plane is primarily determined by the teeth, how they erupt and where they erupt, right? Yes, that's affected by the growth of the jaws, right? The angulation, the growth of the jaws and the mandibular plane angle, all those things. But it's primarily affected by the teeth. And the reason we know that is because we can change it by the teeth, right? If we intrude the posterior teeth, we didn't really do anything to the jaw, but we corrected the occlusal plane angle. I mean, I guess we kind of did something to the jaw because it remodels, right? But you can, or if we extruded the anterior teeth, we could make that occlusal plane steeper, right? So if we're looking at what the occlusal plane is doing, it's starting to tell us a story. So in this case, we know it's more flat, and the anterior teeth are not as far down in the smile, causing the occlusal plane to be, as normal, 7 degrees or so, as it would be. And so why might that be happening? What might have happened? What would have caused these teeth to do that, possibly?
Delayed eruption.
Okay.
Or it could be...
Could be delayed eruption.
Early eruption.
What?
Could be early eruption, too.
Okay, early eruption, posterior teeth, delayed eruption of anterior teeth. What's more likely? I mean, because how often does eruption get screwed up? I mean, by and large, Mother Nature gets it right most of the time. Yes, there's a lot of cases where this tooth comes in before this one. Most of the time when it gets screwed up, a baby tooth had to come out earlier. If they keep their teeth, Mother Nature usually gets growth and eruption it's pretty baked in, right? Pretty solid. But there's a lot of other things that change how teeth erupt. So think about it. What are we talking about here? What affects how far down teeth come? What if this patient had an open bite? What would you suspect? There we go, right? So you put it together when it's an open bite, right? But the same principle applies when you're looking at the depth of the bite in general, right? And the occlusal plane, because all those things are related. So it's possible that this patient either had or has a habit that related in those maxillary anterior teeth not coming down as far as they normally would. So that's going to be a question that you're going to want to make sure to address. So now that we're talking about habits, what kind of habit could have caused this? Okay, could have been a digit habit. If it were a digit habit, would you think that it was in the past or current? Probably in the past, right? So if it's a raging open bite right now, yeah, there's probably something going on right now. But if there was one in the past and now it's stopped, it could have an effect on the occlusal plane like we see here, but it's not currently happening, right? What else? What kind of habits could be currently happening that would present possibly like this?
Sippy cup use.
What's that?
Delayed, like sippy cup use.
Okay, it could, yeah, well, it could be, again, it could be a lot of things in the past. What kind of habit, like currently, could possibly be connected to what we're seeing with the bite here? What about like a blanket, pen, something that's not quite as significant as a digit, but still can affect the eruption of the teeth? All right, things like that. These are questions that you're going to want to ask. When we look at the aesthetics of the smile, besides the smile arc, what else are you seeing about that smile that you would want to improve or change? Yeah, the corridors. What about the corridors? I have large buccal corridors. You can see that the teeth kind of drop off here. Now, why would somebody have large buccal corridors? What's that? Okay, narrow maxilla. And why might they have a narrow maxilla? They're deficient for, that's an argument that could be had. Maybe it was just genetics, right? But then the question I would ask you is, why 500 years ago did people not have narrow maxillas, right? So we're not going to get into it completely, but think about that, right? If we're seeing a narrow maxilla, that kind of starts to add up with some of the things we've already talked about. Maybe there was a habit. All right, so we talked about habits. What other things can cause a narrow maxilla besides a thumb habit or an object habit or anything like we traditionally think about habits? What's that? No, yeah, tongue thrust could, and we didn't talk about tongue thrust, but this could be described by a tongue thrust as well. A lot of times with tongue thrust, we will see space between the anterior teeth, but we haven't really seen how much overjet there is, and you know, so that could be a tongue thrust. What else? What else could result in specifically? Okay, we're on the right track here. So sucking on the cheeks. I have an adult patient that's still in treatment that basically created a 4 millimeter anterior open bite by sucking on her cheeks. Because like she took some photos for her business and the photographer's like, here, suck on your cheeks a little bit. And then she developed this habit and continued to do it, and the entire posterior maxilla basically collapsed and extruded and caused this massive anterior open bite. So 100% it could be something like sucking on their cheeks. Now that's a very less common habit, all right? So there's not like a ton of patients out there that are doing that, but it certainly could be. What is something that maybe close to 50% of kids do that could possibly result in something like this? Any ideas? Anybody? So think about this, right? What do lip bumpers do? They keep the lips off of the teeth, right? And without doing anything else, those teeth move outward. If your mouth is open while you're sleeping, while you're growing, or throughout the day, then what force is being applied to the teeth? You have force from the cheeks, right? That's pushing on those teeth, and nothing supporting it if the tongue isn't there to counteract that force. So when we see and we talk about, you know, open mouth posture, mouth breathing at night, in its more mild forms, this is exactly what we might see. So this is a question that you're going to want to ask, and this is also something that you're going to want to be observing in the clinic, right? Pay attention to them when you're doing your exam. Is their mouth hanging open? Do you notice that they're breathing through their mouth consistently, or are they nasal breathing? What else might you look for if you suspect mouth breathing in these photos? I'm not necessarily seeing it here, but what's that? You could look for inflamed gingiva. Where specifically would the gingiva be inflamed?
Anterior.
Yeah, in the anterior, right? It would be in the anterior and maybe not the posterior. Because in the posterior, the saliva is bathing the teeth and it's keeping the inflammation at bay. But in the anterior, it's drying out and it's causing a more exacerbated effect. So if you're seeing, you know, inflammation of the anterior, not the posterior, that would be one sign. What else might you look for? In this area, oopsie, wrong button. In this area here, what might you look for? Yeah, chapped lips, right? So if they're sleeping with their mouth open at night, there's nothing hydrating the lips. The air is going in and out, in and out, in and out. If they're mouth breathing, it's less hydrated anyway, and oftentimes you'll see chapped lips. Not really seeing it with this case, but again, these are the things you're going to want to start looking for as you're seeing these things in these photos. And we haven't even gotten to any x-ray yet, right? So, and we'll see how many of these assumptions that we made just looking at the patient clinically end up being true when we look at the patient skeletally.
Yeah, so zooming in, so I would tell you this smile in this photo is more of like a social smile, and then he has more of like a guarded smile down here on this zoomed in photo.
Okay, so yeah, he doesn't always. So what was our? So we guessed. What did we guess about inflammation that might be the case?
So
we couldn't see it on the other photo, right?
So you have anterior gingivitis.
Exactly, right. We're seeing it on the anterior in the maxilla primarily, and really not anywhere else significantly, right? All right, so maybe we're on the right track. What else do we see? What do we see about the? Again, so that's his smile up on the top.
Yeah, it was probably more of a guarded smile just because I was taking photos instead
Okay.
of the other one that seemed like more of a social smile.
Okay. Well, let's stick with the center photo down below. What do you notice about the center photo down below? Okay, midline shift. So which midline and why? Lower midline. We have a vote for lower. Tell me why.
It seemed like the upper was to the left, but then I looked at the upper photo and it looks like that's on with its whatever it is.
Philtrum. Okay? So we have a vote with some pretty convincing evidence for the lower. We're going to take a vote with everybody else. Who agrees that it's most likely the lower midline that's the majority of the midline shift? 1, 2, 3, 4, 5, 6, 7, 8. Oh, you got a good following, my friend. All right. Who believes that it's primarily the upper midline that's shifted? Everybody. Oh, we got one. All right. All right. Tell me more. What's going on with the upper?
It might be the way the photos taken, like from that direction, but it feels like I can see more of the canine on the right than I can on the left. Like everything's shifted there.
All right.
And I think the lower does look a little worse.
So, well, just to clarify here, so you're saying you see more of this canine than this canine?
Yeah.
Okay. All right. What else? Anybody else want to throw out an argument for upper midline? Oh, okay, good. We'll get it. Okay, let's go.
I mean, the freedom on the upper is like stretched, but that could also just be the position of the photo.
Could be the photo. That's true. It could be the photo, but it's worth noting, right? Okay, so maybe the frenum's off to the side. We haven't seen like an upper palatal view yet to see if the actual midline suture rugae, palatal rugae tend to shift that way as well. I saw a hand back there. Yep. Okay, so tell me more about. So we nailed it in the mandible. Why that would be the case? Tell me. There's something here that would very, very easily explain why the maxillary midline could be shifted, and no one said it yet.
There's a premolar.
There we go. Right? Yeah. There was a missing tooth on that side, right? And there's a space maintainer there. Now maybe that space maintainer was put in exactly after the premolar or what was it? The primary first molar was extracted, or maybe it wasn't. We haven't seen the upper occlusal to see, right? But when you're looking and trying to determine what's going on with the case, you want all of those data points possible to help you make that determination. Now, I would agree that the philtrum of the upper lip seems to be on with the midline of the maxilla. And even if the maxilla is a little bit off to the side, I mean, at the end of the day, that's usually what we want to line it up with. All right? So even if the maxilla is partially at fault, my default is going to be to, default to the aesthetics. What's the smile going to end up like afterwards? I would rather move the lower midline to match an upper midline, even if it was the upper midline's fault, if that upper midline is on with the rest of the face, if that makes sense. All right.
Yeah, so zooming in, so we have some canine photos, upper canine, lower canine. I know they're really hard to see. We only take 2 anterior PAs.
That's okay. I don't take any PAs, so.
Okay, beautiful. So just based off what I was seeing, like it looks like the canines are in a decent eruption pattern as far as the position of where they're coming in, but they may potentially end up becoming trapped.
Okay, and we'll be able to see it a little bit better on the pano as well.
Yep. And then here we have some bite wings. Those are the most up-to-date ones that we had.
And again, hard to say for sure, but it does appear, at least from the x-ray, that maybe we did lose some space on that upper left side. We'll see when we get to the other images.
So here is the full image series.
All right, let's hone in on the maxillary occlusal view for now. All right, so let's look at the maxillary occlusal view. So we would agree that we have lost some space on that side. Would we agree? Yeah, it doesn't look to be as big as your typical primary first molar would be. Are there any other indicators that maybe this is a maxillary midline shift problem on this view? What are you seeing? I see some heads nodding. What does this look like? Yeah, maybe possibly shifted over a little bit to the left. But again, when we look at the smiling photo, looks pretty close. But in this view, it almost looks like maybe it is shifted a little bit more to the left on the upper. Again, that's something you may have to check out clinically. But if it's not on your radar, you may forget to do that. On the lower, it looks like we've held space a little bit better. That might have been placed a little bit earlier. All right, so maybe we're thinking long-term about getting that midline shifted possibly a little bit back over to the right here on the top. All right, let's stick with the maxillary occlusal view. Go ahead and give me your assessment of the crowding and how you're determining that. So if you had to give it if you had to put a millimeter number of crowding on this case, how many millimeters would you put on it and why? On the upper occlusal.
Me specifically?
Yeah, you specifically.
Probably
we'll give you a shot at it first.
Probably 2 to 4 millimeters.
All right, so walk us through how you're making that determination.
I'm basically basing off the centrals. I'd like to start there as far as the crowding goes. And
Okay.
the only reason I say is because that's like the focal point of the dental arch. So I see that the upper right one is turned mesially and kind of facially.
Okay.
And I feel like to turn that back, I feel like it's about a 2 to 4 millimeters of turn or rotation.
Let's break it down in an even more simple way. Let's just count millimeters upper 2 to 2 first. All right, so if we look here at the overlap, how many millimeters is that? Hold on, you're cheating. All right, how many millimeters is this overlap right? Oh, where am I? Oh, the little, move that mouse real quick.
Yes, I can. Over here?
Yep, oh, here, perfect. Oh, hang on.
Oh, wait, now you're controlling my mouse.
Yeah, it's okay.
Okay.
Don't worry. Oh, all right, worry a little bit. It's not working. All right. Well, we'll just do dark here. Do you see that overlap right there? All right, so how many millimeters overlap is that, would you say?
I'm going to say 2 to 3.
All right, well, yeah, I would say at least 1 to 2. How about here? How much do we have in between those two? Let's see if this will fix itself.
Probably
Sorry.
1 to 2.
All right, move your mouse again one more time.
Yep.
All right. So between the upper right 1 and 2, we have about maybe another millimeter. Between the upper ones, maybe another millimeter. Upper left 1, 2, maybe another millimeter. We're at least at 4. Upper left 2C, maybe another 2. So about 5 millimeters of crowding there. All right. Now, so the anterior, we're saying about 5 millimeters of crowding. Now this assumes, what does this assume? What's the big assumption made here? If we say that's 5 millimeters of crowding, just like we went through it right now, what does that assume? Yeah, it assumes that proclination is okay or ideal. It means that we're not going to retrocline these teeth and we're not going to procline these teeth. All right? If we plan on proclining these teeth 1 millimeter, that opens up 2 millimeters of space, right? It makes our crowding assessment less. All right? So it does depend on where these teeth are. Now, again, it's hard to say from these images. We haven't seen the ceph yet. It's hard to say exactly how proclined or not these are, but they're pretty close. If anything, they might, we might procline them a little bit. Would be my best guess looking at these photos here. So, but if we do it that way, we have about 5 millimeters there. Now let's look from the right side, from the canine there over to the molar on this side here. So basically, all of these sides here. Is there any crowding between that segment? Why or why not? On the upper right side. Is there any crowding from basically the primary canine to the first molar on the upper right side? Why or why not? Where? Well, we counted that with the upper 2 to 2. Yeah. So, okay. So if anything, well, he has the primary. He has his first premolar in, correct? How big is the first premolar compared to the first primary molar? The first premolar compared to the first primary molar. How big are they mesiodistally in relationship to one another?
1.5 millimeters.
1.5 millimeters.
1.5 millimeters, yeah.
What is?
The primary first molar to the premolar is a millimeter.
Does everybody agree with that?
That's leeway space, correct?
Well, you're like halfway right. Yeah, you're thinking of the second molar. Yeah.
Oh.
So the primary first molar and the first premolar. Nobody knows? They're about the same. Yeah, they're about the same. So if the premolar's in, and that's about the same as the primary first molar would be. If we have a primary canine, primary first molar, primary second molar, and we don't lose any space in that segment, should we have enough room for permanent canine, permanent premolars? We should, right? So if we look at that upper right side, it's a wash. We have a primary canine, permanent first premolar, and a primary second molar with the leeway space like you mentioned. So right side should be fine. What about, going back to what we talked about earlier, what about the left side? Do we have crowding, spacing, or is it even as well on the left side? Yeah, it's going to be a little bit crowded. Why is it crowded? Well, we already talked about it. We've lost space in that quadrant. How much space did we lose? I don't know. You can measure it out. It's probably not super duper significant, but probably at least a millimeter, right? So now we're talking 6 millimeters, assuming we don't procline the incisors at all. So this is, a moderately crowded case, all right, on the top. Moderate, borderline severe, but again, if we procline the incisors, maybe we'll be fine there. All right, let's look now at the lower occlusal view, and let's do the same thing, our assessment of crowding. So doing it that way, how would you assess the crowding? So just start with the anterior, and then we'll work our way back.
So starting with the anterior, on the lower you were saying?
Yep.
I feel like it's a very mild crowding down there on the lower anterior 4.
So how many millimeters? Just count them.
Okay, so start with 1. Probably 4 millimeters.
Yeah, so about 1, 2.
About 1 each.
Yeah, 3, 4. I would say at least 4.
Yeah.
Now, do these teeth look retroclined or proclined? They look retroclined, right? If you even just look kind of at where the bone is, facially and lingually, the incisal edges of those teeth are tipped, more toward the lingual, right? If they were more proclined, you would see those incisal edges closer to the facial buccal plate there. And also you see what about the posterior teeth? Are they retroclined or proclined? Yeah, they're tipped in, right? They're tipped into the lingual, right? So let's say we have 4 millimeters for argument's sake. Yeah, we might procline them and get some space. Right side, the same argument, that should be good, right? We have primary canine, we have primary first molar, primary second molar. On the left side, seems like we did a pretty decent job of holding that space. That band looks pretty thick, so we're probably okay on the left side. So there's less crowding on the lower than there is on the upper, right? When we're looking at the entire arch. Now again, if you don't expand this case, then you don't open up as much space to be able to procline those lower incisors because the jaw is going to stay the same place. If we end up expanding this case, well, not only do we make more room in the jaw itself for the crowding that we have, but the jaw also comes down and forward to some extent, which gives us more room to procline those lower incisors, again, helping us to alleviate our crowding. So we have a situation with moderate crowding on the upper, and depending on your treatment plan, mild to moderate crowding on the lower. Let's keep going.
Panoramic radiograph.
Okay, so what are you worried about on the pana? What are you looking at and you're saying, hey, I want to keep an eye on this? And why?
So I would probably say the left premolar, first premolar, does it have space to come in? And if that's not the case, then that left side canine, can it come in as well?
Okay, so you want to pay attention to the eruption of the maxillary left canine and first premolar because we have a lack of space in that quadrant. I would agree. Now, right now, we're looking pretty okay, right? I mean, the canine hasn't deviated mesially toward the root of the lateral incisor. And so, you know, like that could happen as these continue to come down if there's not space, but it hasn't yet, so that's a good sign. Maxillary right side looks pretty much, I would argue, pretty completely normal. We probably had early loss, or at least somewhat early loss of that maxillary right first molar as well, but however it ended up, there was space for the premolar to come down in. Let's talk a little bit about the mandible. What are we seeing there? Anything you want to keep an eye on the mandible, and why?
There's a slight mesial tilt to the lower canines.
Okay, on both of them, for sure.
Yeah.
Yep. And looking at the mandibular left canine there, what else do you notice about its relationship to the primary canine? Besides it being a little bit mesial, which I agree.
I'm not sure.
Anybody? What's the job of a permanent tooth as it erupts?
Resorb the primary.
Yeah. Well, yeah, we have a little bit of overlap. Now, that doesn't necessarily mean a problem. There's oftentimes a little bit of overlap. Sometimes, you know, especially the lower teeth, they tend to erupt either facially or a little bit lingually of the primary root. So it may be that as it continues to erupt, that starts to resorb. But again, that's something you're going to want to put away. Be like, hey, maybe check on that in a little bit. You know, so what if that continues to erupt and that root doesn't seem to be resorbing? Well, all of a sudden, now this canine is going to be more likely to deviate to one side or the other, and most likely to deviate toward those mandibular incisors. So if you just look at this and you'd be like, okay, you know, how often does insurance pay for a pano?
Every 3 years.
Yeah, every 3 years. If you go 3 years in a situation like this and don't check, the problem could already be, in some ways, it could be non-fixable. All right, that canine could be so far over, or root resorption, a lot of things could happen in 3 years. So if you see something like this is not a hugely serious concern right now. But it is something that you want to pay attention to. And it's like, you know, I tell the pedo residents all the time, like, just take panos every year and a half at the most. Like, see what's going on. I don't care if they reimburse you for them or not. You know, get your reimbursement every 3 years. That's fine. But you need the information. Like, it's not worth missing out on that information just to, you know, for the insurance reasons. Like, I hate it when insurance dictates treatment. You know, start with what your ideal treatment is, and then whatever you can get from insurance, great. But don't let the insurance dictate the way that you practice. I don't think you would want that kind of care. I don't think you do like that kind of care when you get it, especially in the medical world, right? It's not ideal. So start with ideal and work backwards. So we want to pay attention to the mandibular canines as those continue to erupt. Going back real quick to the maxillary canines, if you had to guess if those were more facially oriented, more palatally oriented, or right in the middle, which one would you guess and why? I heard in the middle and I heard facial. So let's hear the facial argument first.
They're vertical, very vertical,
I only brought one little gold dollar today, but if I brought a second one, you would have got it. Yeah, that's exactly right. So they're more upright. So the more upright the canines appear on the pano, and the less magnified they appear, the more likely they are to be facial. Now, could it be right in the middle? Sure, it could be right in the middle. But it's less likely to be palatal in this situation here. And so, again, this is something that we'll continue to monitor as we go through. At the end of the day, it would be really nice if we had more space in the upper jaw for these teeth to erupt. And it would be kind of nice if this smile filled the buccal corridors. We 100% want to make sure we're asking airway questions about, there's enough signs and symptoms here that we want to ask the questions about sleep. We want to ask about snoring. We want to look at tonsils and adenoids. If you have a 3D image, you can do that a lot easier. And it does seem to indicate that, like, maybe this child would benefit from having a larger upper jaw than they do. Let's go to the next one.
And a Ceph without a nose.
Yeah, so we'll have to... We've gone through this a lot with the radiology department. So if they do that, just make them fix it. Yeah. But what do we glean from here? So we made a lot of assumptions based on our profile photo. Now, there's a lot of things that are going to make this Ceph harder to diagnose. So one, you can see that the patient's head is tipped up here as well. So when you look at selenosion, I mean, that's quite significantly tipped up. But when we look at skeletally, what are we seeing skeletally about the facial height of this patient? Is it more dolicho, more brachy, or mesocephalic?
From the mandibular plane angle, I would say dolicho.
I would agree. Does anybody disagree? Like, it's interesting. So you look at the mandibular plane angle, that's quite obtuse. You can see how the lower jaw itself does not look necessarily short, in my opinion. Or does it to you guys? Does it look like no? So what's happening here? This lower jaw is growing fairly normally from a length standpoint, but this direction of this growth has been more downward and backward, resulting in, if anything, a slightly increased lower third of the face. But at the same time, we had something happen with the teeth that made the occlusal plane a little bit more flat than you would expect from the way that these bones were skeletally growing. So when we're talking about, what can we do from this point forward to help this child grow and develop as ideally as possible, the way that I'm thinking about this is, hey, I want the upper jaw to be as forward as I can get it right now. I want it to be wide enough to support the midface and to get all the teeth in, that this patient has. And I would love for the direction of this mandibular growth, the length of it, to be directed more forward and less downward. All right? So genetics is a huge component of how a patient grows, but if we wanted to do something to help a patient's lower jaw grow more forward versus more vertically, and I'm not saying we're changing the overall length that the mandible is going to end up, what I am saying is we're changing the overall direction of that growth to be more forward than more vertically. How might we do that? You could have rotation of the mandible. All right, so that's a good point. So if we're thinking of this case comprehensively and they had all their teeth, 100% you could intrude the posterior maxillary teeth and add some, and allow for some auto rotation of the mandible. Obviously, this isn't a comprehensive case yet. So what else can we do to help encourage forward growth versus more vertical growth? Where do bones grow? Like, why do they grow the directions that they do? What's that? What about soft tissue? Let me ask that question a different way. If I put a suction cup on your bone and left it there for months, what would happen? I mean, obviously you'd have to do surgery to do that. But if I could, I put a suction cup on your forehead and I leave it there for 2 years and then I take it off. What's going to happen? What's that? You're going to have a bump on your forehead, right? So that's really easy to understand when we talk about bone physiology, right? When does a child grow? When does a child grow? What time of the day does a child grow? Child grows at night, right? That's when growth hormone is released. That's when growth is happening. That's why sleep is so important to kids. That's why kids who have severe sleep apnea don't grow. I would suggest, and not me personally, but I've heard this recommendation and I agree with it. If a child is on the low end of the growth spectrum, I do not think they should be put on growth hormone until they've had a sleep test, because it may just be that. And if you just throw them on growth hormone, yeah, you might fix their growth problem to some extent, but you're not fixing the underlying problem that caused it. So if kids are growing at night and soft tissue affects the growth of bone, then what soft tissues are at play as it relates to mandibular growth? Where does growth of the mandible happen? Primarily. So growth of the mandible, the body of the mandible is happening at the ramus. Where else is growth happening? As it relates to the forward dimension, I guess if the ramus get longer, it gets forward. Where else does growth happen in the mandible? What's that? Does growth happen in the mandible at the condyle? You guys, you don't seem convinced. Does anybody think it doesn't happen there? No, growth happens at the condyle, right? You see this. The distance between the condyle and the coronoid process will elongate and become longer. And yes, the body of the mandible is part of that. As a child grows, the head of the condyle becomes longer, all right? So when we're talking about having an effect on this growth, all right, the head of the condyle is going to respond to the forces that are placed on that, which are specifically the articular disc and the capsule, right? And that's all connected via soft tissue to the skull itself. So when you have a jaw that's hanging open, you have forces on the condyle that are going to cause that growth to be more vertical. Additionally, you don't have anything stopping the maxilla from continuing to erupt. And so you tend to see hypereruption of the maxilla, and you tend to see more downward, backward growth of the mandible. Even though genetically, I understand they're going to be programmed to grow a certain length of mandible. I get that. But the direction that grows is going to be dependent on all the other factors that are at play when that child is growing, which is when they're sleeping, which is why we encourage them to be nasal breathing, right? So you can do that with, getting them to be able to breathe through their nose, hopefully with, expanding, opening up the nasal passageways. That's going to be helping. Or you can do something like lip taping. And we won't go into lip taping in extraordinary detail. I just got some crazy looks right here. But, lip taping, you want to be careful with it, right? You don't just prescribe it to everybody. The way that I recommend it for kids is actually on the sides of the lips. It's not sealing their lips at all. It's just keeping their mouth closed. So basically, they'll go on either sides of the lips, and they'll stretch the chin skin a little bit to keep the mouth closed so that when they get into deeper REM sleep, which hopefully they're doing, their jaw's not going to drop back, and they'll be encouraged to breathe through their nose. If they throw up or if they have any issues at night, their mouth can still open. So it's not, yeah.
Outside of the commissures?
Correct. I do outside the commissures, yeah. And if you look at lip taping, if you haven't looked into lip taping, I would look into it. I would look at the research that's there. I would look up all the warning signs about it, and I would experiment with it yourself, right? Because I've taped personally a lot of different ways. When I first started taping, I just taped straight across my lips, and it was great because my initial symptom was congestion. If you are breathing through your mouth at night, you're going to wake up congested all the time. All right, so I just sealed my lips off from the side, and it was great. I didn't wake up congested anymore. It was awesome. It was like my whole life I'd been congested, and I didn't wake up congested anymore. And the physiology, we can go into it, nitric oxide, the whole things. We won't today. So then I was like, all right, well, maybe I'll just start taping vertical. I saw some things on that. And, I still was waking up not congested, but I was like, I felt like I was snoring less. And I was like, that doesn't make sense. Like, why would I be snoring less? And so then I started experimenting with taping on the sides because it allows me to use more tape and actually put more force to keep my mouth closed at night, still waking up not congested, but also less snoring. So again, that's the way that I recommend taping. It's also less freaky for parents to try out. I don't recommend taping in kids under 5, and that's basically because they're, if anything happens to a child under 5 in their sleep and they were taping and you had recommended it, it's a liability issue. So would I tape my own kid under 5? Possibly, that way, depending on what the symptoms were, or at least in some way I might. I definitely wouldn't do it in any kids under 2, all right? And another reason for that is SIDS risk, right? Their body is not developed enough to be able to always support their breathing, period. So under no circumstance would I ever tape a kid under 2, even my own kid. Between 2 and 5, it's a cost-benefit analysis for me. For my patients, I'm going to recommend they're at least 5 before they tape. That way they can kind of understand the process. It's not something that's being done to them, so like emotionally, all that kind of stuff. And I would never force a kid to tape either. So that's just my personal belief on it. But anyways, we want to keep the lower jaw closed while the patient is growing to help direct that as far forward as possible. I recommend ENT referrals when I see possible allergies. And the ENT will either do their own allergy testing or send off. A lot of times they'll put them on Flonase or a mild steroid. If it's more severe, they might need to go on an antibiotic to clear up the sinuses and things like that. You bring up a good point, and that's why I didn't want to get too deep into mouth taping, because I don't want the message to be like, just go home and tape everybody. There's a lot more to it. You want to make sure they can tolerate tape, right? So if they can't walk around with their mouth closed for 2 minutes, like a normal kind of brisk walk, then I wouldn't tape. There's other issues going on that need to be addressed before they will be able to tape. And you'll see, like if you try to tape them, then what's likely going to happen is their sleep ski either going to get worse or they're going to be taking it off every single night because they can't tolerate it. Yeah.
What kind of tape are you using? Maybe that's a dumb question.
No, it's a good question actually. So there's two kinds of tape that I use. Exactly, duct tape. No, no, it's funny. On myself, I started out with Scotch tape, but I know, right? It works pretty fine. But some people have sensitivities to tape. So there's two tapes that I primarily recommend. One is a 3M micropore tape. It's pretty inexpensive. It's really thin. It's also very strong. Like if you're not careful, you can tear skin. So especially on kids, I usually stray away from that. There's also by the same company. It's called NextCare though. It's a blue tape. Also 1 inch. It's a little bit more expensive, but it's more hypoallergenic and it's not quite as strong. So with kids, I'll recommend the NextCare tape first. Yeah. All right, we are running shy on time. Let's keep going.
That is pretty much the last photo. I only have one other photo left on my presentation.
Okay, we took a smiling profile photo. And, well, this, if anything, it helps us to see a little bit more. We'll go back to the Ceph real quick, actually. We didn't really look at the proclination. Yeah, so, I mean, proclination, like our assessment, I think, was correct. If this head position was correct, it probably is a little bit retroclined. We're probably going to move those forward eventually. All right, so let's go to the photo again. And here you can see, this is another view that, in my opinion, shows that the upper incisors have not extruded as much as you would expect in a normal case, especially if they're growing hyperdivergent. Lower facial height is coming down more. There was probably something that was going on that was preventing those incisors from erupting. And let's go to your problem list. Yeah. Or your next, or what do you got next?
Yeah. So this is kind of what I put together. I'm also not an orthodontist, so if I'm incorrect on all this stuff, I apologize.
I don't think anybody in here is yet, right? So we're working on it. Well, I mean, one, yeah. All right. So here's when we and we'll do the new template list. Here's when you're deciding. You always have to make a decision on phase one. Are you going to treat the case or are you not going to treat the case? Or rather, are you going to recommend treatment on the case or are you not going to recommend treatment on the case? So in my opinion, the best way to determine this is to go through your problem list and ask yourself the question for each and every one of those things. If I don't do something now, can I fix it just as well later? Okay? So, I mean, problems are problems. I can see problems, in a 2-year-old. Doesn't mean I'm going to do anything about it, right? I can see crowding in a 2-year-old. Doesn't mean I'm going to put braces on him, right? So are there problems now that if I don't do something about, like, I can fix just as well later? If the answer is yes, and I can get the exact same result and fix it exactly the same way later, then I'm going to wait. I mean, there's no benefit in doing it now, right? You can put them through treatment at one time and address all the concerns at once. But if there are problems on your problem list that if you don't address now will result in either 1, higher risk, or 2, a suboptimal result long term, then I'm going to recommend treatment. And the range between those two is large. All right. Sometimes it's like, oh, well, maybe there's a little bit of increased risk. Maybe the result will not be quite as good. And sometimes it's like there's serious risks, and you could have really big problems long term if you don't do something. Right. That gray area is difficult, and you have to decide as a practitioner how to manage that. I try to leave that up to the patient. I try to be as honest and open with them about what I'm seeing as possible. And my treatment coordinators hate it because they want me to just come in there and they say like, hey, you need this. Like, this is what we're doing. But on some cases, it's hard. It's borderline, and it's not as clear. And so I'll try to go through with them the risks and benefits. I will tell them what I would do if it was my child. All right? Doesn't mean it's right, but it's what I would do if it was my child. And that can help because sometimes that's all they want to know. All right? But I'm not going to judge them or shame them if they don't feel the same way about it as I do after I've given them all the information that they need. So when we're looking at these problem lists, all right, so, normal divergent, obviously that's not technically a problem, so no reason to recommend treatment for that. If they were hyperdivergent, like we said, a little bit, again, probably not something in and of itself that would warrant any treatment at this point, right? We're gonna be able to address those things later. Dental class 2 molar, all right, something that we treat all the time in phase 2, but like, is there any indication to treat standalone a dental class 2 molar in a child? No, not really, right? Unless, so it's not that would be the issue. Blocked out 6 through 11 now, or number 6 and number 11. Now, you can argue about the percentage of likelihood of these canines coming in, but this is a problem, right? This is something that we've identified that could potentially lead to either a suboptimal result or increased risk. All right, this child, if the canines become impacted, might need surgery. All right, kid can die in surgery. Right? I mean, it's a small risk, but it's a risk. Right? So, you can decide what risks you believe are worth intervening for or not. But if we go back to, is this my child? What would I do? I'm going to minimize the chances as much as possible that I have any issues with those canines. Not that I'm worried about them dying in surgery. I mean, that's like 0.000 whatever. You know what I mean? But the result could be suboptimal. And if they have an exposure, they might end up with recession, which is a lot more common. They might end up with, a dehiscence in the bone. All these types of things can happen with canine exposures. They might get ankylosed on the way down. The surgical exposure could be too aggressive. It might stop moving. We see all these kind of things all the time. So if I'm worried about canines and it's my kid, I'm going to open up space and give them the best chance possible of coming in. So for me, that's an indicator of a phase 1 treatment there. For you, it might not be. All right, 10% deep bite, 2 to 3 millimeters overjet, not really worried about that at all. Straight facial profile, again, we kind of worked through that, maybe a little bit more convex in this case. Symmetrical facial features, that's not a problem. Midline shift, mandible to the right, 2 millimeters. That is not necessarily the problem, right? Why that happened could be a problem, the space loss on that side, all right, which we would be addressing if we were to treat this case. And I don't think we got an airway questionnaire, did we?
I don't believe so.
Yeah. So there is an airway questionnaire in Axiom. I would encourage you to get it on every single patient, whether you see signs or symptoms or not, because it's just questions. And the answer to those questions could help you to be able to see other things that you might not be paying attention to if you don't ask them. So I would encourage you to ask them. As far as the sleep goes, I mean, if there's no sleep test and we don't know how they're sleeping, then we're not going to use that as a justification for treatment, but it's certainly a justification to ask more questions and figure out what's going on there. So let's go ahead and jump to your treatment plan.
Again, not a training orthodontist, also not an orthodontist, but you could justify bonded expander as far as how much expansion. I leave it up to the orthodontist to tell me how much expansion is needed. I think 2x4 bonded braces would be nice because you could do arch development with an arch wire. That's just my take on it. And 2x6 bonded braces if we had more permanent teeth developed. The objectives is definitely to make space for the 6 and 11 for optimal eruption pathway and arch development.
Okay, so we're not going to get to our second case. I'm realizing this, but that's okay. What we can do is we can treatment plan it together, and then you can present it next month. We have 2 things here that we recommended. We've recommended expansion and we've recommended partial braces here, right? All right, so I want to talk about those individually because this is really, really important. So with expansion, all right, what is our goal with expansion? What problems are we addressing? Transverse discrepancy, and why did we decide that was important? Yeah, I mean, primarily to make sure that the canines have the highest chance of coming in as possible. Now, I know we talked about all that other stuff, about the buccal corridors, about all those things, right? So in order to make more room for the canines in its entirety, we need, or ideally we would have the bone become wider, right? Because the teeth can only erupt in the bone that's available, all right? So our goal with this case is orthopedic expansion, meaning that if we measure out the jaws before and after we do our treatment, we should see that the actual width of the bone of the maxilla is wider, okay? And so in my experience, that's why I would use a bonded RPE in this case. Now go back to your panel. Now, when we use a bonded RPE, we need anchorage, right? What is the anchorage for skeletal orthopedic expansion in a case like this? The teeth, right? The teeth are the thing that's connected to the bone. So we have a permanent tooth on the right side. That has a good root. That's great. We have a baby tooth they have the E's are still there. The second primary molars are still there. They seem to have, at least a little bit of root left. So that's good. And then we have primary canines, right? And they have a little bit of root left as well. I would have loved to have seen this patient 2 years ago and treated them then because you would have had more solid baby tooth roots and your anchorage would be better and the resistance of the maxillary suture would be less. The older you get, the more interdigitated the maxillary suture becomes. And you get to this is almost to the middle phase where I hate treating. Because it's like you have limited anchorage, you need skeletal expansion, the child's getting older, the baby teeth are coming out, the permanent teeth aren't in yet, and at that point, most of the time, I'll pause and wait for all the permanent teeth to come in and do a traditional Hyrax or Haas type expander later, or if it's a really severe discrepancy, something like an MSE or MARPE to make sure that we get the skeletal changes. But in a case like this, in my opinion, we're at the tail end of predictable orthopedic expansion. If we lose too much of those primary molars, or they come out and the premolars haven't erupted yet, then we're in a situation where anchorage is going to be limited, and we're either going to have to increase our anchorage by something like TADS, which is a little bit more aggressive, or waiting until the permanent teeth come in. And I would make that determination based on how much skeletal expansion I need. We didn't measure this out on a cone beam, but if we did, my guess is this jaw size discrepancy is probably between I would say 3 and 5 millimeters skeletally, all right, which is how much we want the bones to move, which is actually quite significant. I mean, it's hard to get 3 to 5 millimeters of true skeletal expansion in a patient this age. So my recommendation would be we cover as many of the teeth as we can. I would cover the posterior teeth, and we'll work through this after class, but we need to design the appliance and how that would work. But we'll want to cover the molars, of course. We'll want to cover the primary, second molars. Hopefully they're not mobile at all. That would be something you want to check clinically. And I would cover all the way up to those primary canines, creating basically one unit with the expansion to get as much anchorage and as much skeletal change as possible. So that's how I would design that expander. Now, the bonded expanders have acrylic on the occlusal of the posterior teeth, which, if anything, can cause some intrusion of those posterior teeth, especially depending on how long we keep it in there. If we wanted more intrusion of the posterior teeth, we could have the lab add additional acrylic to the posterior, to the top of the expander, and that would cause the patient to open up more. Maybe not great temporarily on trying to establish nasal breathing at night, but maybe it would help us long-term by intruding those posterior molars, allowing the lower jaw to auto-rotate forward, and potentially helping to normalize the angle of the occlusal plane. Now, I wouldn't write home about that, especially if you're doing just an expander in 4 months. That effect is probably not going to be significant enough to make a huge, huge difference. But if this was like a skeletal protraction case, where you were actually doing protraction to mesial, or to bring the maxilla forward as well, and the expander was going to be on there for a longer amount of time, then that would be something that I would consider a little bit more highly. So expander is going to address our orthopedic change. You also recommended braces, all right? So why, if you don't do braces now on the front teeth, are there things that you won't be able to correct later, or you won't be able to correct as well later? I would agree not, yeah. So braces, in my opinion, is more optional with this case. Now, you can make the argument of a couple things. Well, both ways. So one, are there risks with braces at this age?
Yeah.
What is the primary risk with braces at this age? Yeah, that would probably be the most catastrophic, right? So if we place the bracket in the wrong spot, if the roots get distalized, if, whatever, if we adjust, or even if Mother Nature just, causes that canine to go over and we happen to have braces on there, there's a liability for us and there's a risk for the patient, right? So, I mean, like, you have to weigh, is that worth it to you? The benefits are, like, aesthetically, right? You could have improved aesthetics. Now, his aren't terrible. I don't know if that was a concern of theirs or not.
Guardian concern.
Yeah, so the parent's concern. I mean, and that's legitimate. So again, you have to weigh, and social concerns are huge, right? I mean, so if the parent's concerned about it, I mean, if the patient's not already, they might become if their mom's concerned about it, which, can sometimes be a little bit sad, but it's the truth, right? So, I mean, that has to be weighed against the risks of, if we put brackets on there, how risky is it? Now, the canines are past the apex of the root of the lateral incisors, and if we're expanding, we're going to open up a lot more space in the maxilla in general. So I would feel that the risks of root resorption or causing root resorption with braces are relatively low in this patient. So if the parent was like, hey, we'd love to straighten them up at the same time, I would not hesitate or have too much reservation about that. I would be fine with that. If the canine roots were higher, if they were more angled toward the lateral incisors, I would tell them I would not do that. I had a patient come in this week that was a second opinion, and the other orthodontist had recommended braces, and I talked about expansion only, and that was the reason why. The canines were right on top of the root of the lateral incisors. And in my opinion, it was too risky at that point to put braces on those teeth until we had more space. And so we went ahead and did the expansion only. So the other benefit of braces in this case, I know we're wrapping up, is if we procline the teeth a little bit, we will have the additional space from the proclination. We'll also make a little bit more room for the lower jaw to be able to possibly posture or come forward and have a little bit of a mandibular repositioning appliance effect on the patient. So I think you did a great job with your, do you have any more slides? Is that it?
No, that was
yeah.
it.
All right. So yeah, you round of applause. Very good job. Yeah, first time doing a case presentation, so hopefully it wasn't too crazy scary. This is how they'll go. So have a great rest of your day, and yeah.